So thanks, David, for asking me to come and talk about this today. As David said, I am involved with the Order of Malta for the last 15 years. I'm a specialist reg in emergency medicine in Crumlin at the moment, just transferred from Sligo, and currently I'm also from Mayo, so that's your geography lesson for today. So that's just a bit of the hashtag. I'm really big into Twitter now. I'm getting into the Twitter handle. Miss Dribbles is my name. Won't go into why it's called that. And I was actually looking through all the tweets yesterday and today, and it's just really exciting to see how many people of a voluntary setting is here out of their own accord on a Saturday, have given up time, money to come here, and it's really, really exciting. My little disclaimer is that I am from Mayo. I'm a big Mayo GAA head. I am a culchie. I'm very active in the Ballina Order of Malta, and I've trained a lot of the CF4s within the Order of Malta as well, around the country. But my graw is for Mayo, mainly because of the rurality of it, also because of the response times of the ambulance. So I know that the communities so need the CF4 responders, and I've been actively involved in training them and also in pre-hospital arrest in a voluntary setting down there. But my day-to-day job is in the emergency department and also with the resuscitation team that when a patient needs to come into us. So for yourselves, your CF4s, you've done your job, your role is fulfilled, you've had your adrenaline drive, you've had all your bits and pieces in the car, you've gotten out there, you've now had the AED, you've shocked the patient, the ambulance is now gone. You know, you've done all your work. You're handed a cup of tea or something stronger, and you just have those few minutes to think to yourself, what the hell just happened there? And what happens then? You go home to your families. You go home, you continue on with your day jobs, or you do whatever else that you do. And it's all quiet. But do you ever get to know what happens afterwards? And I would always encourage people who are active in a resus, in a pre-hospital setting, to follow on. You may not get the full medical details of what's happened with the patient, but I would be very conscious of if there's a bystander CPR or a CF4 that's been on scene, to try and make contact with them, to thank them for their efforts. So, as the last speaker was saying about the pre-alert that you get, and you get that nice kind of jolt up, sometimes, well, most of the times, we will get a pre-alert within the resus. So we have a resuscitation team that happens and all comes together. So if we could get a 5-minute warning, it's great. We're excited. We know that there's a ROSC on scene, so we know that it's all hands on deck for this. So in our emergency department, in our resus room, this is Sligo's emergency department, we have all our equipment all laid out in a strategic manner so we know exactly where to go. 5 minutes that we have for prepping, everybody gets a job. More often than not, I'm actually the leader, because I'm the small little blonde one that stands there at the end of the bed and delegates the tasks. But it's great to have the overview and see exactly how things are going. Someone's on airway, someone's on breathing, someone's on circulation, somebody's doing drugs, and it's all absolutely flowing great. This is our lovely emergency resus team in Crumlin at the moment, and that's me there. As with everything in emergency medicine, we love rhythms and we love algorithms. So we actually have a post-ROSC algorithm, which I don't need to go too much into it, but it's really handy to have. We have it with all our other CPR algorithms. I just flip it over, have it in front of me. It doesn't make me any less of a doctor to have that in front of me. In fact, it makes me even more competent because I know I'm not going to remember all these drugs. I'm crap at maths. So I will always have it written out in front of me to know exactly that I'm going to give the best care for the patient. You're all taught about the airway, breathing and circulation. It still continues on with us in the emergency department as well. So we have a pulse, ye have the pulse, you're transferring the patient into us then, and we're excited about it. So these are our 3 main aims in the emergency department, what we have to do. First of all is to stabilise the ROSC patient. Formulate a plan for this patient. What's going to be their ongoing care? Are they going to leave our resus department to go upstairs to intensive care? Are they going to leave it to go for a transfer out for a cath lab? Or are they going to leave it, unfortunately, for the mortuary? So we have to have this as an ongoing plan and reassessing the whole time. And we need to make an evidence-based assessment for our post-arrest patient prognosis, which I'll talk about just one slide at the end. So, airway, breathing and circulation. When the patient comes into us, depending on how they're brought in, if they're brought in from paramedics, sometimes they may not have an airway put in. Advanced paramedics sometimes have tubes already put in. We need to really try and take over physiological aspects of that patient to really try and minimize any hypermetabolic state that that patient is going through. We do not want oxygen to be wasted in this patient. We don't want the body to be into such an overdrive that it's actually going to use up all the oxygen, use up all the energy that's spent. We can take over that. We'll take over the functions. So we plan to do an advanced airway. We kind of assess it for about 10 or 15 minutes. If the patient has no airway in, is making some sort of a reflex to cough or swallow, it feels like that they're coming around, then we may just stand back for a few minutes and see how it goes. If they do not have any breathing or they do not have any adequate breathing, we need to take over that to get the mechanics of getting air from the outside into the throat and in through the lungs and in through the windpipe. So we plan to do an endotracheal intubation. So we visualize the vocal cords, put the tube in for it. We can then move on to breathing, so we can control the breathing. We can give oxygen. We can allow and control the oxygen that we give in and also the carbon dioxide that the patient will breathe out. So we're taking over that function of the patient as well. We really want to avoid hypoxia, the low oxygen, because we need good tissue perfusion for that patient, for their brain and for their heart as well, to maybe just to function for the next few days. We also want to prevent hyperoxia, so we don't want to over-oxygenate the patient. And this is something that's coming out in the literature quite recently, that in fact by giving too much oxygen, we can actually end up doing damage to cells and damage to myocytes, which are the special cells that are in the heart as well. So we titrate between 94 and 98% for oxygen. Sometimes we'd pass an NG tube as well, which is a nasogastric tube from the nose in through the mouth to try and prevent any abdominal distension that was going to put pressure onto the lungs so we won't get good oxygenation. And that's just another little tip that we do. The circulation, so we really want to take over the dynamics of the circulation, because in a post-ROSC patient, their blood pressure is very low, their heart rate may be very low as well, and they may also have just their not ability to perfuse their bodies. So we could take over that ourselves. We could put little lines in through their arteries to try and control that. We could give certain medications as well to be able to increase the contractility of the heart, or we could do it to increase the conduction, so the electricity of the heart as well. And this is all done within the first few minutes when the patient arrives. Disability, which really is how aware the patient is of the situation. So are they conscious? Have they come round? Or are they still in a comatose state where they actually have no responses at all? So we sometimes would sedate patients to allow us to do all these physiological functions. But we have to be very cautious, because if we have a patient that's actively coming around, we don't want to sedate them too much to now knock off any reflexes that they have. One big thing that we do want to control, though, is seizures. And seizures, unfortunately, can be quite common in the post-ROSC patient, mainly because there's such a lot of electricity going through with the brain. There's a lot of hyperdynamic activity going on with it as well, but it is actually an indicator that this patient may not do very well. Each seizure that they have will use up a huge amount of oxygen and a huge amount of energy as well, so we really want to control that. Exposure, so temperature control. I don't know if anybody's aware of, and I think, David, you were saying earlier on about the really decrease in the temperature of the patient. I have one slide on that, just to say that what we do is we just expose the patient. We do not allow them to get too warm, and I'll explain why. Glucose, there's not really much evidence about what glucose, but we know that if somebody goes into a really hypermetabolic state, so some big injury has happened to them, sometimes they can go over and they can get very high glucose. There's no evidence really to show if we need to actually tightly monitor that, but that's something that we do all within the first 5 minutes. So after that, we really need to find out what's actually caused the arrest. So we have to do 12-lead ECG, see if there's any thing that would suggest that this patient has a big heart attack, because if there is, we could give drugs there and then within the first few minutes to try and clot bust any clots that are there within the heart. And where I've worked before in Sligo, we would do that for patients if they were suggestive post-ROSC with an MI, which is heart attack, because we didn't have a cath lab, so then they would be transferred out for a cath lab. Chest x-rays, I wouldn't see too much of it, exactly what you're going to find in that. You might find some evidence that the patient might have a lung problem, might have a collapsed lung, maybe in a post-ROSC or post-CPR status. Bloods take about an hour to come back, so don't really worry too much about them. We do have certain bloods that would come back within a few minutes that would give us an idea about the acid base of the body. And then ultrasound. I'm very excited about ultrasound because it's right beside the bed of the patient that you could use it to see whether or not this patient has a good working heart, has a heart attack, or even has a big major clot in their lungs. So this is what we do. We take over the physiological control of the body if we can and if we need to. We try and identify and treat the underlying cause, and then we'll identify whether or not this patient has to go to a cath lab, to go to a cardiologist, an emergency transfer, to go in and see if they need stents put in. Or thrombolysis. Like I said, certain places don't have access to the cath labs, so we would thrombolyse ourselves, give the clot-busting agent on a ROSC patient suggestive of an MI. So this is the hypothermia I was talking about. Before, there's been loads of studies to show that if we manage to cool the patient, then there may be a good neurological outcome in the next few days. So the targeted temperature management of a patient suggests that we should have the patient cooled to between 33 and 36 degrees. In fact, what's actually come out in the last few years is that we actually need to avoid pyrexia. We actually don't need to be cooling them down to 33 degrees, but we just need to be avoiding this 37 degrees, because with each degree that they go up over after 37 degrees, they have an increased risk of mortality. So all these money that was spent on big cooling blankets and all this bits and pieces may not have been the best thing. It's just exposing the patient and making sure that they don't go over the 37 degrees within the first 2 days after a ROSC. So the prognosis, which I think somebody's going to be talking about later on as well, some of the neurological findings that's very good. If they've got a good light reflex in the first few minutes when they come into us, if they have a respiratory effort and a cough, then that's very good. And if they maintain those for 72 hours, that's good. If they have a seizure, though, unfortunately, it's not a great prognostic indicator of the neurological outcome. Advanced age increases the short-term mortality, but it doesn't predict any neurological outcome. As somebody was saying earlier on, that they've had arrests from, I think it was 1 year up to 102 years of age. Although somebody's coming in as a 98-year-old person, this 98-year-old person might be down doing their shopping and celebrating their birthday in Eddie Rockets, versus somebody who's 60 that you think might be a very good function at 60 but may not well be. So age, although it doesn't really determine your neurological outcome. The type of arrest does, so any non-cardiac causes, PE or asystole, really doesn't have a great effect on your neurological outcome. Your downtime, your geography, where you are, if you're urban or rural, your delay in getting to the patient, and the quality of CPR all has a huge effect on whether or not you have a good neurological outcome. So the neurological outcome is done at 72 hours and also at 5 days post-ROSC, and that's usually done upstairs in the ICU in the intensivists. And what the 4 main things that they look at is the clinical, so the response of the patient, reflexes, etc., biochemicals, so their bloods, EEG, which is a brain waveform, and then imaging, so any CTs that maybe need to have has this person had a huge brain bleed that's caused it. That's just not a reversible cause. So I apologise that it's 2013 because I'm only after reading that the OCAR report was out for 2015 in the handout, but there was about 120 patients that were alive on discharge in 2013 from a pre-hospital, out-of-hospital cardiac arrest. They were all graded as their cerebral performance category 1, 2 and 3. 1 is a very good functioning person, so somebody that maybe even to go back to do a mild bit of work. And then what we did see is that 88% of the patients that were discharged from hospital had a good score, so they were actually able to get themselves involved back in society again. And that's a huge thanks to yourselves. So my conclusion is really thanks very much for all your help. I love hearing that we've had ROSC on scene. You're a huge, invaluable resource to the community and especially into the rural communities as well. So thanks very much, and always come back to us, find out what's happened to the patient just for your own learning. Thank you.